Hi, my name's Dr. Quinlan, and I will be presenting the first portion of this presentation on therapies that are currently available for sickle cell disease in Manitoba, as well as just a little bit about why do sickle cells sickle, how does that harm the body, what to do if you have a pain crisis, and we're also going to spend a bit of time talking about hemoglobin SC. Now, sickle cell disease is genetic, and it is caused by a mutation that forms something known as hemoglobin S. And actually, this is only different by a single amino acid, yet it causes such a huge change in how the red blood cell functions. These cells form crystals, so they become quite rigid. They don't flow nicely through the vessels, and because of that, it's quite turbulent and they get damaged. Now, if you only have one copy of this gene, you have something known as sickle cell trait. It's important to know you have it because you could pass it on to your children. If you have two copies, then you have sickle cell disease, and that's where things can get complicated. Now, hemoglobin S, which is the abnormal hemoglobin in sickle cells, is really bad at holding on to oxygen. So whenever it is in a low oxygen environment, it lets go of its oxygen molecule, and then it changes from this normal round shape into this crescent or sickle shape. And as you can see, they tend to get lodged in the vessels, and when they do that, they actually cause a low oxygen environment downstream, which then causes more sickling, and it's a vicious cycle. This is what's happening underneath a pain crisis. Now, because of this, sickle cell patients only live to about 52 years old, and on average, that is about 20 years loss of life expectancy. Now, how this disease manifests, it's quite numerous. You can have strokes, you can have heart failure, certainly bone damage, kidney damage, but the main thing is that it causes pain, and not infrequently. Now, before we go into this slide, which covers when during somebody's lifetime they're likely to have certain complications of sickle cell disease, I want to touch on a very important topic, and that's called hemoglobin F, or fetal hemoglobin. Now, when you're in your mom's belly as a baby, you actually don't make hemoglobin S at all. You make this type of hemoglobin, which is fetal hemoglobin, and it does a very good job at holding on to oxygen, unlike hemoglobin S, so it does not sickle. Now, once you're born, you no longer make that, although there are a few people who tend to make a little bit, and they actually often have less severe disease. But as a general rule, you stop making it once you're born, and you start making this abnormal hemoglobin, which then starts causing issues very early on. So as early as 2 months of age, you can start having pain crises. You can have these things called spleen attacks, where the spleen captures all of the red blood cells in the body. So instead of the red blood cells flowing around in the vessels, they're all stuck in the spleen. That causes really low blood pressure and can result in something called shock, which needs an ICU admission and can actually be fatal. Acute chest syndrome is caused by sickling in the lungs, and that can cause lung damage, and in fact, it's one of the most common causes of death in adults with sickle cell disease. Now, the idea is the earlier we intervene with treatment, the less likely you are to develop the complications on the right-hand side of the slide. And some of these include stroke, which can happen as young as just a few years of age. Once you've had one stroke, 50% of patients will have another in 3 years. Earlier on, they tend to be from brain bleeds. Later on, they tend to be from clots. Pregnancy concerns for both female and male. And as I mentioned before, bone damage, eye damage, kidney damage, maybe even requiring dialysis, as well as heart failure. One other thing here you can see is skin ulcers. Now, interestingly, you can also have skin ulcers from being on hydroxyurea. Yet having sickle cell disease can also do it completely on its own, and they tend to occur near the ankle. So what do you do if you have a pain crisis? If you're managing this at home, it's important that you rest, stay well hydrated, take Tylenol and ibuprofen, or if you have opioids that we've prescribed to you in clinic, and make sure you're monitoring your temperature. If you have a fever more than 38.5 degrees, you can't control your pain, you're not able to keep fluids down, you're really short of breath, chest pain, any of those things means it's time to come into hospital. And currently, we only have one drug that prevents this, and that is called hydroxyurea. If you are a patient of Dr. Houston's, you have definitely heard about this drug before, and that is because it is recommended to everybody with sickle cell disease. So how does hydroxyurea work? Well, let's go back. I mentioned earlier fetal hemoglobin and how it's really good at holding on to oxygen, how it doesn't sickle. Hydroxyurea tricks your body into making that again. So if we can get higher levels of that good hemoglobin, we know that you are less likely to have pain crises, less likely to have that acute chest syndrome, less blood transfusions, fewer hospitalizations, and survival increases. This is a study that looked at the probability of 10-year survival between individuals taking hydroxyurea and those who were not. And you can see that there was a 20% increase in the likelihood that they would be alive at 10 years if they were taking the drug. Now, I think I'd like to talk about a few myths about hydroxyurea, and these are common things that I hear in clinic. The first is that it's a chemotherapy and that it has a lot of toxic side effects like hair loss, which is not true. The other is that it doesn't really matter if you're that consistent about taking hydroxyurea. You can take it every other day if you'd like. You're still going to get good benefits. And that's not true either. People would think that because it's supposed to do so much good that it would be costly. But in fact, if you have a health card, it will be covered. The higher the dose of your hydroxyurea, the more side effects you will experience. Your white blood cell and platelets might be a bit lower, certainly still in a safe range, but you won't have side effects otherwise. That would be more severe if you were taking a higher dose. That doesn't happen. The next is that it's a new drug, so we don't know much about it. It's been around longer than I've been on this planet. And lastly, that it cannot be used in pregnancy or breastfeeding. This is a little more complicated. It's a discussion, and that's why it's important that if you are in the process of family planning, that you mention that to us in clinic so that we can help make decisions about what will be best for you. Now, this is a study that looked at whether or not increasing the dose as much as you can of the hydroxyurea resulted in better outcomes. What I mean by that is that they pushed the dose up until the point that the platelets and white blood cells were on the lower end of normal. And by doing so, they had 57% less pain episodes, 73% less of the acute chest syndrome, 70% less transfusions, and 79% fewer hospitalizations. You can also see here their hemoglobin levels were much better, and they had less hemolysis, or red blood cell breakdown. So again, hydroxyurea dosage matters. However, it will only be safe for us to increase your dose if we know you're taking the medication consistently. If you're skipping doses, then it's not safe for us to increase the dose. If you need a little bit more proof, this is a real case. Now, this is a 18-year-old female. She had hemoglobin SS, and she is one of those who is lucky to have just naturally high fetal hemoglobin. Despite that, we started her on hydroxyurea, and you can see that initially there's this increase in her hemoglobin and reduction in red cell breakdown. We increase the dose even further, and these benefits become even more pronounced. So that just goes to show that if you can increase it, you should. Now, there are some side effects of hydroxyurea. Certainly skin and nail changes would be the most common. It can cause darkening of the nail beds as well as darkening of the skin. As I mentioned, it can cause rarely ankle ulcers. However, just having the condition also predisposes you to that. Not everybody gets the same bang for their buck, so not everybody is going to be a great producer of fetal hemoglobin. However, most people get some benefit. And sperm count can be reduced, though this is presumed to be reversible. Now, this is a recent study that was done on individuals under the age of 18 with sickle cell disease. They were all going to go get a transplant. And prior to that, they did something called ovarian cryopreservation, which is when you take out the ovary, and they do that so that later on in these patients' lives, if they want to have children, they'll have the option. But it's interesting because some of these people were not on hydroxyurea and some of them were. And that was a really good opportunity to see if there's any differences, because it's long been thought that the low hormone AMH that occurs when you're on hydroxyurea means that it was harming fertility. What this study actually found is that it actually is more reflective of egg function, not egg count. So they found that the number of resting eggs was the same, regardless of if you were on the drug, and there was only a slight drop in the number of developing eggs in the patients on hydroxyurea. So in other words, it affects how they grow, but not how many you have. Again, I think there's more research that needs to be done in this, but this is an early positive indicator that in fact this drug is worth considering, especially if fertility is one of the concerns you have. Now, L-glutamine is also available in Canada. In the United States, it's sold under the name Andari, and they have what's called marketing exclusivity, meaning no one else can sell it, so they charge a lot for it. And in Canada, you cannot buy Andari, but what you can do is go to a supplement store. It costs about $46 for a month, and we recommend 15 grams of powder twice a day. This was a study that looked to see whether L-glutamine at this dosage was helpful, and they found that there's a 25% reduction in pain crises in people taking the medication. Now, I mentioned we were going to talk about hemoglobin SC, which is less common than hemoglobin SS and has long been considered to be the less severe type of sickle cell. This is not always true, however. People with hemoglobin SC can have very severe disease, and in fact, they can have even more issues in terms of eye and bone damage. You get hemoglobin SC if you inherit one copy of hemoglobin S from one parent, and then another type of abnormal hemoglobin called hemoglobin C from the other. And what's interesting here is you can actually see on the slide that they form these crystals, which is very characteristic of this condition. This is a phase 2 study that looked to see whether hydroxyurea was beneficial. And what they found was that there was a 62% reduction in pain crises, less hospitalizations, less red blood cell breakdown in those on hydroxyurea. And super cool, actually, is in mice models, they found that very small increases in hemoglobin F completely prevented sickling. And interestingly, even when the hemoglobin F did not increase, sickling was still reduced. So clearly hydroxyurea is doing other things aside from just increasing the fetal hemoglobin. Lastly, and this is sort of a newer thing, at least in Canada, is bloodletting or phlebotomy to cause iron deficiency. This is done more in France. And what they find is that by keeping these patients iron deficient, they have less red blood cell breakdown, less inflammation, and really just less severe disease. So if you have hemoglobin SC, I hope that you, next time you're in clinic, are open to discussing some of these things if you're not already on a treatment plan. Now I'm going to turn the remainder of the presentation over to Dr. Houston, who will be discussing curative treatment in sickle cell disease.
Okay, good morning. Thank you. Thanks very much, Katie. That's a terrific introduction to sickle cell disease and all of the problems and challenges that it causes and the currently available treatments that we have to use, routinely in clinic. Those treatments really can work extremely well, but they are inconsistent. So everybody benefits from hydroxyurea to some extent probably, but not everybody benefits to the extent we'd like. So of course, there's always a search for newer or better treatments. Anytime I talk about sickle cell disease, I'd like to make a dedication to my friend and colleague, Adi Alujahungbi, who was here in Winnipeg for a relatively short time, but taught me a lot about sickle cell disease, partly because of his expertise as a hematologist, but partly because he was also a patient with sickle cell disease, who unfortunately, as you can see, before his 50th birthday, succumbed to complications. So even people who have access to the best possible treatment and the most knowledge don't always do well. So we'd like to be able to do something better. Can we cure this disease? Well, yes, we can. There's no question we can cure it, but it's not clear that that should be for everybody. For a few carefully selected patients today, and we'll talk about that, I think the future is very bright, and we may be able to offer that kind of treatment more routinely. There's a great, great hope. So what are the curative therapies for sickle cell disease? We can do, there's basically two. There's bone marrow transplant, and the idea in bone marrow transplant is you replace the blood-producing cells from the patient with blood-producing cells from somebody who doesn't have sickle cell disease. Pretty simple in concept, a little more challenging in implementation. And the second approach is gene therapy, where we actually modify the patient's own bone marrow stem cells to change the genes in a way that inhibits this sickling process. Now, both of those, at least as we currently do them, require a step where you have to clear out the patient's bone marrow. So there's a very toxic step involved, and that's one of the limitations of these procedures. Just for a minute to talk about what is the bone marrow, because we're going to talk a lot about bone marrow, and why is that so important? The bone marrow makes blood cells, and you have to continuously make blood cells because the circulating blood cells wear out. They have a finite survival, and they have to be constantly replaced. And neutrophils have to be replaced every few hours, platelets every few days. Red cells normally last over 100 days, but they have a much shorter red survival if you have sickle cell disease. So the bone marrow is sort of like the garden where you grow all of these blood cells for your circulation. And the seed that you plant that garden with is called the hematopoietic stem cell. And all of the blood cells can derive and be produced from that single stem cell seed. And that is what we are transplanting or what we are modifying. So there's a little cartoon generated by AI trying to show the garden of all the blood cells growing. Okay, so our first option for curative therapy is bone marrow transplant. And we've been doing bone marrow transplant for a long time, for over 60 years for treatment of leukemia. But it's a very complicated procedure with a lot of variables that can be adjusted. And it still is not, the optimal protocol for doing this for sickle cell disease isn't that clear. Most bone marrow transplants have been done in kids. They tolerate it far better than adults do. And indeed, I asked my colleague Chris Paulson to look at the Canadian Bone Marrow Transplant Registry, and up until 2024 in Canada, only 20 adults had had bone marrow transplants, although 9 of those were done in 2024. So this is a growing interest in implementation, and 6 of them were done with haploidentical donors, which we'll talk about in a minute. So in order to do bone marrow transplant, there's a bunch of steps you have to go through. First thing is you got to find a donor. And the donor obviously has to be somebody who doesn't have sickle cell disease and should be as immunologically similar to the recipient as possible to prevent immune reactions between the host and the donor immune system. You have to then give a conditioning regimen to clear out the patient's sickle-producing bone marrow, because you want to get rid of that, and to make room for the donor marrow to grow. And that conditioning regimen also has to suppress the recipient's immune system so it doesn't reject that donor marrow. Then you infuse the marrow. This is actually just given intravenously. Those stem cells know where to go. You don't have to, the transplant is not a surgical procedure. It's just a transfusion. They know where to go, they set up. But it takes a long time for that garden to grow. When you plant the seeds, you don't get fruit immediately. You gotta wait, and that you have to support the patient for several weeks until their blood counts recover with the donor the donor blood. And you have to give immune suppression to prevent a reaction, because when you transplant the donor marrow, you're also transplanting that donor immune system, and it can reject the patient's body. And so you have to give immune suppression to control this thing called graft versus host disease. So this is just a cartoon. So you collect the marrow stem cells from the donor, you isolate them, you store them. In the meantime, you are giving your patient chemotherapy to clear out the bone marrow. Then you infuse the donor cells, and then, not shown on the cartoon, you have to give immune suppression. So there's a lot of variables in bone marrow transplantation, and it's very complicated, and getting it just right is a process that takes a lot of refinement. You can get a bone marrow, the best bone marrow donor is a matched sibling. So 1 out of 4 of our siblings will be a perfect HLA match for us. And that's great. But not all of us have 100 siblings. And of course, that sibling has to not have sickle cell disease. So as it turns out, really probably only 1 in 6 people has a sibling donor available. So that's nice if you got it, but not most people. If you have leukemia, and you don't have a sibling donor, we would automatically go to the bone marrow transplant registries. There's millions of people around the world who've signed up to say, yeah, if you're a match for me, that the chance of matching some stranger is extremely small. It's like 1 in a million. But if you got millions of people, you can often find a match. But the problem is that most of those people signed up in those registries are Caucasian. Most people with sickle cell disease are not, and the HLA distribution is quite different. And so the chances of finding a donor for a sickle patient are much lower. It's only about 1 in 3. So that's not, sometimes we find one, but that's not great. So the big breakthrough has been the development of haploidentical transplant, where you use somebody who's only a half match. Up until very recently, we couldn't even consider that, but some tweaking, a remarkable, surprising tweak to immune suppression allows us to get away with this, because almost everybody has a haploidentical donor. If you have a surviving parent, a surviving child, you have a haploidentical donor, and 3/4 of your siblings will be at least haploidentical. So that kind of solves the marrow donor problem if we can make it work. There's a whole lot of variations on that conditioning regimen to clear out the marrow from extremely toxic to pretty darn toxic. So there's risks with this, right? The reason we don't do this for everybody is because of these challenges in finding donors, but also because of these risks. So with that conditioning regimen, this is a 4-week hospital stay when you're waiting for your counts to recover, the risk of bleeding, risk of infection, risk of organ damage from all of this, a risk that the graft doesn't grow, and so we didn't cure your sickle disease after all, a risk of this immune reaction of graft versus host disease, which can be very, very nasty. It can be just a mild rash, but it can be a horrible chronic illness that's very different from, but easily as bad as having sickle cell disease. The conditioning regimen, most of them probably reduce fertility, and most of them probably increase the late risk of cancer. So this is not without its hazards. This is some data from a large international transplant registry looking at who get, almost 1,000 people who had transplants for sickle cell disease. Note that most of them were children, so almost 2/3 of these were children. And on the right, the numbers on the right are the bad outcomes of either death or failure of the graft. So children did way better than adults, but even in kids, it's pretty risky. And in adults, like 1/4 of these transplants failed. It was way better if you had a matched sibling donor, so your risk of a bad outcome was much lower if you had a matched sibling donor, but remember, few of us happen to have one. And the conditioning regimen seemed to make a little less difference. That being said, those are older data. This continually is refined, and there was a recent report, this is still not fully published, of a multi-center study. But, these studies are hard. They only had 42 people in this study, even though they had 19 centers participating. They included adults, but mostly they were pretty young adults, 22 or so years. And they had, come up with a protocol using haploidentical donor transplant. And so the results are pretty good. About 1 in 20 died. About, so 7% had the graft failed, so the procedure was a failure. About 1 in 20 had this bad graft versus host disease. But 83% of people survived without severe graft versus host disease or graft failure. So pretty good, but still some risk. Um, I think we really want to see that other centers can reproduce this kind of result, that, because the devil is in the details of how patients are selected and so on. But it's extremely promising. Okay, can we do something even more space age than that? Yes, we can do gene therapy. And this is very exciting, where instead of dealing with all this immune stuff with a host, you just fix the patient's own cells. Well, isn't that a good idea? So for gene therapy, you start with the patient, you have to harvest, mobilize and harvest their stem cells. We actually can collect them from the peripheral blood, but that's can be challenging to get enough of them. In the test tube or in the laboratory, we then modify the patient's stem cells. Meantime, while we're doing that, we are giving the patient very high dose chemotherapy to clear out their bone marrow. And then we infuse the modified cells. And just as in the bone marrow transplant situation, we have to wait and support the patient because we've just planted the garden with seeds and we got to wait for the garden to grow. And that takes weeks. So again, there's that risk of infection and bleeding during that period until the marrow can grow. Two completely different strategies have been developed. The science of this is so powerful nowadays that two completely different ways of doing this have been done. Both work. Both are actually licensed in the States, but only the second one is licensed at the moment in Canada. One where you add a normal beta globin gene to make sort of normal hemoglobin. But I think the more interesting one is the one where you modify the regulation of that fetal hemoglobin that Katie was explaining, that you have when you're a fetus in your mother's womb, that inhibits the sickling of the polymerization of hemoglobin S. So the more hemoglobin F you can get, the less sickling you have. And if you get the F up towards 50%, the sickling goes away completely. And this uses this very high-tech thing of CRISPR-Cas9 to edit the genome. Very exciting stuff. So this, in order to do this, though, you still have to collect the stem cells for the patient. So you mobilize them with this product called plerixafor. You purify the stem cells. You use this CRISPR-Cas9 thing to modify BCL11A, which is a negative regulator of hemoglobin F. So you take out BCL11A, F goes up, and then you have to give that ablative conditioning regimen to wipe out the marrow so that these modified cells have a space to grow. The trial that got this product licensed only had 43 patients. Some Canadian centers, Toronto, participated in this trial. And just to give you an idea of how tricky this stuff is, they screened 80 people to get 2 onto the trial, and one of them didn't mobilize enough stem cells. So actually only one actually got the treatment. So yeah, it's exciting, but it's not that easy, and not everybody's available. Anyway, so they did this in people 12 to 35. You had to have bad enough sickle cell disease that was worth it, that you had 2 or more vaso-occlusive crises per year, but you had to not be so sick that you wouldn't get through this tough treatment. So here are the results of that trial with the product is called XSL is the brand name. The top curve is the total hemoglobin. So hemoglobin went way up because red cell survival is greatly improved if they're not sickling. And the bottom curve is the amount of the hemoglobin that was hemoglobin F, and it's almost 50%. And you can see that at least out to several years for the follow-up available in this study, the expressions, everything looks pretty stable. So it does look like it's a cure, although we don't have follow-up beyond a few years. This is what's called a swim lane plot. So each of those horizontal bands represents the course of a single patient. The blue triangles represent when they had a pain crisis, and that kind of pink line in the middle is when they had their transplant. So to the left of that pink line is the 2 years leading up to their transplant. And you can see everybody had a lot of pain crises, right? I mean, they had to, or they wouldn't get onto this study. And to the right of that pink line, after their gene therapy, almost all of the patients stop having pain crises completely. So a few still did, but most just stopped. I mean, so it cures people. It is very exciting. But it's risky, and it's risky because you have to give this ablative step with a very intensive high-dose busulfan to clear out the bone marrow, and a risk of infertility and latent malignancy. Anytime you're monkeying with the genome, there's always a concern that you're going to break something else. And if you break a cancer-regulating gene, maybe you'll cause cancer. That has been a very big worry with some of the other gene therapy approaches that use retroviruses to get into the genome. That's not as big a worry with the CRISPR approach that's the one approved. But there's still concern that you'll, have some other effects. And as I say, the follow-up is relatively short still. Compared to gene therapy, bone marrow transplant has one huge advantage. You don't have to worry about finding a donor. It's the own patient, and so there's no risk of graft versus host disease. Those are big advantages. Disadvantages are also cost. So at the moment, the US list price for one of those gene therapy products is $3.1 million. The other one is $2.2 million US. So although I said the one product has been approved in Canada by the regulator, Health Canada, the body that sorts out funding is still negotiating it, and the provinces have to make it, they will negotiate with the company, and we'll see whether that's going to actually be funded in Canada. And unless you've got a lot of coins in your couch cushions, this is otherwise going to be hard to support. But I think the future is bright. I think that the current gene therapy product is actually not the one that is going to be the one that makes the big difference. And there's some extremely exciting stuff coming where maybe we can actually, instead of taking the stem cells out and modifying them in the laboratory for other gene therapies, for hemophilia, we just infuse the vector into the patient and it modifies the cells in the body. And there's another very cool approach that's sort of based on the same principle of knocking down BCL11A, but it uses a drug that binds the RNA. Remember, there's DNA translates into, it's transcribed into RNA, and RNA is translated into protein. So instead of modifying the DNA, you just block the RNA step. Totally specific. It's a drug, it's an injection you give once a month. Might be very cool, but it would be a drug that you would have to keep taking. So this, just to summarize for both of us, the options for drug treatment are likely to improve. Right now, we just have hydroxyurea and L-glutamine, but there's a lot of drug development going on. Katie didn't have time to tell you about some new drugs that are going through the paces, like mitapivat. Bone marrow transplant protocols keep getting better, and if we see those kinds of results with haplo-identical transplant, reproducible in other centers, that's going to be easier to offer that to patients. Gene therapy also is getting better and very exciting. I think it's very important to remember that even if you cure the sickle cell disease, you aren't going to undo damage that's already occurred, and sickling causes organ damage through the body. So the sooner we do it, the better it is. Okay, so just a patient can get in a pickle when red cells take shape like a sickle. The S hemoglobin that causes the problem can slow the blood flow to a trickle. When sickling causes pain crisis, it defines one might say what not nice is, though no panacea, hydroxyurea can suppress the root cause, hemolysis. And whoops, well, there's one more. For sickle cells, is there a cure? If we pick the right patient, sure, we can do BMT or gene therapy, but some risks they'll have to endure. Okay, that's enough of that. Okay, so questions. When do you think curative therapies? So, as I say, the gene therapy is licensed by Health Canada. It is not actually available, both for funding and for logistics today. I think that, but the next question is right on target. If we start to make gene therapy available, this is the kind of very complicated treatment that should really be done in a small number of centers that do enough of them to maintain or achieve a high level of expertise, because complicated therapy needs expert teams. So I wouldn't imagine that this would be done in Winnipeg, at least in the near future. If a few Canadian centers, Toronto, Vancouver, take this on, people would have to leave Winnipeg, and that'd be difficult because you'd have to leave Winnipeg for months and months. Next one, bone marrow transplant we can do here. Are we doing many transplants in Winnipeg for sickle cell disease? So no adults have been transplanted in the Winnipeg program. We did have one adult who went and had a transplant at the National Institutes of Health a few years ago on a study protocol, but they do quite a few pediatric transplants. I apologize, I can't give you the number, but they do them routinely, several a year. Yes. Is it true? Okay, scroll down. If you're good enough response to hydroxyurea, you don't need gene therapy. I think that's a really good question. I think at least today, if you're doing well with hydroxyurea, you should stay on hydroxyurea. People who do well with hydroxyurea can do really well with hydroxyurea. And that's probably safer. But it's, this will be a changing discussion as our technologies get better for treatment. Yeah, that's a terrific question. Yeah, that's a terrific question. This is one of the kind of the dark sides to all of this. Fertility tends to be pretty important in people's minds. And I get that. And so we obviously want to have a complete discussion when we're talking about these things. That is one of the downsides to the current gene therapy protocol with that busulfan myoablation. It is pretty sterilizing. I think that's going to prove. I think the technologies will change. We've got other ways that will be developed to achieve that clearance of the bone marrow, or we'll be able to do it where we just infuse the vector into the patient and skip that ablation step, and that'll be good. Does hydroxyurea have side effects? Well, yeah. It causes discoloration in the nails. In some people, they'll get darker. Some people notice their skin gets a little darker. It always lowers the white count. We adjust it until we lower the white count, but we monitor that and we do not lower the white count too much. And other side effects, nausea, all that kind of thing, very uncommon. A few people will tell me they feel unwell on it, but most people feel a whole lot better on it. If you're a carrier, it can be a donor. Yes, you can. If we had if we had an AA donor and an AS donor, yeah, we'd take the AA donor, but an AS donor can be a donor. Yes. Retinopathy. Yeah, so the retinopathy is a huge problem for SC disease. At least half of my SC patients have at least some degree of this eye problem in the back of the eye that can progress to vision loss. We have engaged with the ophthalmologists, and one of the ophthalmologists in particular sees most of our patients, is becoming very, very expert in this. They have measurement treatments, laser treatments and injections that they can use, but also treating the disease. So we are increasingly getting people on hydroxyurea, and as Katie mentioned, make phlebotomy to cause iron deficiency seems a bit radical, but we're getting our heads around that as well.